Please allow me to introduce our next speaker. We have the privilege today of hearing from the esteemed Dr. Ash Panchal, a resuscitation researcher who focuses on pre-hospital care, airway management, and evidence-based guideline development. Dr. Panchal is an associate professor of emergency medicine for the Department of Emergency Medicine at The Ohio State University Wexner Medical Center. He's passionate about improving patient outcomes in the pre-hospital setting and conducts research focused on pre-hospital airway management and improving outcomes from cardiac arrest. He began his career as a researcher, completing a PhD in cardiovascular physiology at the Case Western Reserve University. Following this, he completed his medical training and residency at the Ohio State University College of Medicine. Dr. Panchal is an immediate past chair of the American Heart Association Emergency Cardiovascular Care Science Subcommittee, also known as the AHA-ECC, those real important things we read at the beginning of all the AHA stuff. And he's also the chair of the 2020 AHA-ECC Adult Basic and Advanced Life Support Guidelines for Cardiopulmonary Resuscitation and Emergency Cardiovascular Care. That's a mouthful. Building on yesterday's presentation around the 10 steps to improve in-hospital cardiac arrest, quality of care and outcomes, I'm really eager to hear about how Dr. Panchal will add another insightful layer to the advances in resuscitation. His impressive experience promises to not only inform our field, but also have an impact on our care for veterans. I've heard Dr. Panchal speak before. I've seen him on a regular basis. He does go by Ash, so please call him that when you see him. Let's give a warm welcome to Ash Panchal.
Thank you so much. And awesome music choice, by the way, fantastic. I wasn't going to do the Shake It Off, so I don't have that kind of style going. Thanks so much for having me. I am amazed and astounded by the number of people here, and I'm excited to talk a little bit about resuscitation today. Let me grab my little clicker, because I'm not going to get very far without that. So today, I think the best place to start is where all of us kind of like to start. We're all healthcare providers. The thing that we love to do over anything else is we love to share our stories, right? We all have stories. We all have something to tell about. But when we share our stories, we do it for a lot of different reasons. We want to share our successes. We want to share our challenges. But oftentimes, it's to debrief, right? It's to lighten that burden, release that load that we're carrying. And today I want to give you a story, and we'll go from there, okay? So, sorry. There's always disclosures. We'll worry about that later. So the stories that I want to share with you is about a family. It's a husband and wife who are just coming home, and they're like, okay, the day's done, we're tired. Okay, so we're gonna wrap up this day. Wife is, of course, fatigued and tired. She's postpartum and starts to go upstairs to her bedroom, and he's downstairs. As she's going up the stairs, he hears a clatter. He rushes over and finds her at the bottom of the staircase. At the bottom of the staircase, he's shaking her, calling her name, trying to get her attention in some way, and she's not doing anything. He doesn't know what to do, but he knows one thing that he has to do. He needs to call 911, and he does. The operator on the phone does exactly what they're going to do. Hey, EMS is on the way. Can you do CPR? He's confused, distraught. He doesn't know what to say. It goes on for a second, and he says, I don't know what to do. It goes on for 4 anguishing minutes. Heart unbeating. EMS arrives. They get CPR started. Resuscitation's going on. They do defibrillation because it's a shockable rhythm. Don't get her back. Continue CPR and take her to the hospital. At the hospital, resuscitation continues, and the discussion begins. Does she have a PE? Does she need embolectomy? Does she need ECMO? Is she too far gone? Should we just give up? These are all familiar themes that every one of you in this room has heard about, experienced, known about throughout the process. As an ER and EMS physician, I've seen these things happen in people's homes, to their loved ones, in the hospital, across the board. And one of the things that I've focused my career as a researcher on is debriefing these scenarios. I'm an educator. And so I debrief these and try to understand what's going on. And when we talk about the themes that our clinicians talk about, the theme that underlies all of this and is at the base of all of it is I wish I could do more. And I wonder if a lot of you feel that same concept. I wish I could have given that medication faster. I wish I did better CPR. I wish that I drove faster. All these wishes that we have. And it really puts us in a tough space. And it makes us ask ourselves certain questions. So I want to take you down the road because we have a good happy ending from this story. Okay? You can see the hands being held. Mom's okay. Now the thing is, not all stories have such a happy ending, right? And the challenge is even when we have these happy endings, each of us throughout that moment afterwards are always thinking the same thing. Those little evil demons in our brains are always saying the same thing. Could I have done more? Could I have done better? Am I good enough? That's powerful. Am I good enough? Because we're calling ourselves out. Am I the one who's responsible? And so the crazy thing is, every one of us in here, we're educators. We have amazing power to confront this concept. We can inspire, we can educate, we can prepare. When someone's prepared and someone feels that they're well trained, that am I good enough, that voice becomes smaller and smaller. And that's the key. There's a lot to unpack first thing in the morning, guys. There's a ton. But let's be honest. With every single morning, there's a beautiful sunrise, and it's a new day to do amazing things. And that's what we're going to do today, guys. What we're going to do is we're going to confront this question head on. Okay, we're going to try to answer this question in a couple different ways. First, we're going to start by looking at resuscitation and outcome goals and try to understand that. We're going to look at the dynamics of competency and try to understand what exactly competency is all about. We'll look at levers for achievement. We want achievement, we need those levers to move it forward. And last but not least, I love to talk about the special sauce. There's got to be a special sauce. There is for everything else. So we're going to talk about the special sauce. Okay? So hang on. We'll make our way through this and go from there. Okay? So let's start with the first basics. I know Camilla did a great job yesterday telling you a little bit about cardiac arrest and in-hospital arrest. I want to touch base and so make sure that we have the same standard concept. Is that both out of hospital and in-hospital arrest, we have a ton of work to do. And when we think about the number of people who are affected by both these disease processes in our community, that red person on my image here, those are our survivors. Not very many. Not very many, and the fact of the matter is, this is something we can change. And so that's what we got to work at. Now, how do we change this? One of the biggest change pieces that all of us are aware of is our chain of survival. We can enhance our chain of survival, strengthen those links, and those links themselves will have such a powerful impact as we look for improving outcomes. Now, we're not the only ones who've caught the concept that this can make a difference. Our friends at JCAHO have. And this is an exciting thing. Like sometimes we look at this and we say, okay, JCAHO, you know, it gets us a little bit, but the fact of the matter is that means we're making a commitment as a community to change outcomes from cardiac arrest. That's what it comes down to. So they released these revised recommendations which really focused on leveraging the science to focus our attention on patterns to improve patient care. Now, when we think about these focused areas, I'm going to focus on one particularly, but we should touch base on these right now. Resuscitation services being available at hospitals, having post-resuscitative care strategies, having a hospital collecting data for performance, and having hospitals who comply and analyze that data. These are fundamental pieces that all go into a larger structure. But I'm going to pull us back for 1 second to the first one, where we're starting to think about the concept of training our staff. And you don't have to read this whole thing. I'm going to bring you down to the bottom of this, where we talk about periodic basis thereafter as determined by the hospital to continue education. It should happen at orientation, periodically, and whenever staffing changes. Kind of general. It doesn't make me comfortable. It shouldn't make you comfortable because I'll be honest, mom and grandma do not want periodic question mark training. They want assured competency, right? I think we want all of our surgeons to have been the person who has done surgeries every single day of their lives and can do my gallbladder with their eyes closed, not the one who does it every once in a blue moon, right? That's the reality. Should there be anything different when we think about saving someone's life? Across the board should be the same, right? And so it begs the question, are we competent? Now, this is going to be we're going to come back to this word competence like 60 million times. So you can, if you're playing the drinking game in the background, don't, because competence is going to be something we're going to talk about a lot. And so when we think about competency and the strategies, we talk about gaps, talk about skills, the knowledge, the courses, what we're learning. One of the words that struck me on this is reflection. Reflection. Because we don't do nearly enough of that. But when we start using some of those more interesting words on the fringe, rigor, gaps, all those kind of concepts, we're starting to get into more detailed ideas and infrastructure which are beyond what we would basically say is what I get from my basic training. And so what is competency? So when we think about the concept of competency from the educator's perspective, it's the ability to do something successfully and efficiently. And I wanted to tack on this little thing about safely fulfill the patient's needs in society. Half of my job these days is I'm the Research and Fellowship Director for the National Registry of EMTs, which is a certifying body for EMS. And one of the things we always talk about is when we think about minimal competency for EMS providers, that means grandma who lives in a rural town all by herself in her little house gets the same care that someone who lives in Washington, D.C. or is actually in Congress gets. There's no difference. Okay? That's what we want. And we need to satisfy both of those individuals' care no matter what. And the question, though, that I think we get caught up on as educators is the concept of what is this level of competency, right? I mean, is the level of competency that of, I'm a resuscitationist, I do this all the time, I can do CPR in my sleep, or is it I just finished and I'm just graduated right now and I'm ready to be on the rig or be on the floor? And so the concept of this beginning competency being our minimal competency may be something that we as educators want to challenge. So when we think about the certification process and everything that you're going through, may you be a nurse, may you be a physician, may you be EMS, no matter what you do, you're going to have some sort of certification process. You'll have your initial education, you're going to have your national certification, licensures often, sometimes local credentialing. But the key thing is you're going to recertify and you're going to wash and wax this for the next 20 years of your career. Now, the thing is, when we look at this, one big process here is we're doing this to protect the public. We want the people that we are taking care of to be safe. Now, for them to be safe, do you really think it's minimal competency that we're going for? Now, when we try to define this, we really need to think about the competency level we want to train people at. We want our providers to be current, to actually learn the material they're supposed to know, and on top of that, actually be trained to the setting that they're in. And that would be their outcome variables that are goals in those settings, as well as the specific nuances of those settings. So when I say settings, I'm training in a couple different areas. I do in-hospital cardiac arrest, I do out-of-hospital cardiac arrest, so my populations are variable and the goals and the things that I have to train to may be different in both settings. I mean, in the in-hospital setting, I really honestly hope you're not going to face a hoarder house. That shouldn't be what you face, right? But what we should face is similar outcome variables for resuscitation outcomes. So I'm going to redirect us a little bit from the pre-hospital space to in-hospital cardiac arrest, where I spend a lot of my time. And so let's start with the basics. Let's understand what we're doing in the in-hospital setting that means that we're actually saving lives or not. So Paul Chan, him and his team looked at resuscitation, Get With The Guidelines resuscitation, and they looked at the outcomes and all the data from that data set. And this is actually something that I've pulled up in a lot of different talks that I do because it's so powerful to really give us insight. So what they started by doing is they took every single organization, every single hospital in this data set and broke down and did something special. They did risk stratified survival rates. Okay, so when we say risk stratified, I think we can get a concept of this when we think about cardiac arrest. So someone who has a cardiac arrest, who has a shockable rhythm, is one person. And I think all of us right now are thinking, good survival. I can save them. Yay, this is gonna be awesome. Then on the other side, you have your cardiac arrest with asystole, who's been down for 15 minutes and did not have bystander CPR. Now you're like, okay, I gotta work here. So now you have those two balances, but if we wanted to stratify and understand what the overall survival is, we control for those factors and we say this is our baseline, this is where everyone kind of lines up, so everyone's kind of equal. So they did this for the Get With The Guidelines data set, and they came up with this beautiful bell-shaped curve. I say beautiful sarcastically, because what this means is that you have a huge amount of variability throughout there. If I wanted to actually set up like a high-stakes test, like so say you're a physician and you're taking your boards, right? You want that skew to be way to one side, saying everyone's passing because they're brilliant, right? That's what I'd want for this. But instead, I have a bell-shaped curve with my survival rates going all the way from 9% to 37%. 9 to 37. My survival of my family members in a hospital should not depend on which hospital I'm in. Yeah, I'm seeing the nods. Thank you. That's the truth, right? And so we know that's where we're starting. But we can do something with this, right? So what Paul did is he took these people and he broke them into quintiles to say, hey, here's my best people and here's my worst people. Let's look at some of the characteristics which make the best people really the best. And so we know what they're doing. And so we broke this down and he gives us the highest on the far side, the lowest on the near side, and the middle is, well, the middle people. But what we're going to talk about is what do they do? So what do they review? How often are they actually looking at in-hospital cardiac arrests? And what we're finding is they're looking at this at least monthly so that they are actually really engaged in the outcomes. So if you're looking at something on a monthly cycle, that means that throughout that month you're collecting all the data so you can review them. You're actually taking the time to actually look at it yourself first, put into a PowerPoint slide, which we love to do, right? And then you're actually feeding it back to somebody else for a discussion. So that's good. So you have engagement there. So what do we look at? So there's a lot of different things that you can look at also. You can track your hospital survival rates. You can look at your times to defibrillation. You can look at your interruptions and compressions. And these different aspects is what defines our higher performance groups. They're looking at these concepts to actually look and see if what's going on in their hospital system. Now, the cool part about this is we know the survival rates, we know the different characteristics which matter. Let's put it all together and look if there is an association between characteristics and survival. And of course, I'm going to show you that. So in this table, you have the association between hospital factors and risk stratified survival rates. And what I'm giving you here to look at are adjusted odds ratios. So odds ratios over 1. 1 is basically you're at the balance, and anything higher than that means that things are going in the right direction. So what kind of factors came out and really shined for us? First, if we review arrests at least monthly, or maybe even more, what you're starting to see is you're going to start seeing lots of improvement in your outcomes. Look at that, almost 7-fold improvement in outcomes for survival for our patients. Additionally, when they will continue looking at this, monitoring our interruptions specifically and taking the time to look at interruptions had a huge impact. Now, there's a lot of things that I find that are really impactful, and a lot of things that we're talking about which really drive us are things that we look at and we say, oh, here are my interruptions, here's my debriefing, here's all these things. But there's got to be someone to do this stuff, right? There's got to be someone who does this. And so Paul and their team asked a great question. Do you have a resuscitation champion? Do you have someone that you can lean on when there's a bad outcome who's actually going to sit down and talk to people and really debrief this scenario and improve our outcomes? And guess what? That's you. That's all you. Hey, welcome. And so amazingly enough, if you have a true resuscitation champion in your shop, your outcomes will be better. So if you haven't heard it today, or yesterday, or at work the other day, you matter. Every single one of you matter. You being here, you doing your job with resuscitation equals survivors. That's a fact. Take that to the bank every single day because it was published in JAMA. Okay? Own it. And so the fact of the matter is, if we know we matter, that means we have to focus on what those tasks are that we need to do the next thing. So our work equals survivors. What's our work? So how do we achieve competence? Again, we're back with competence again. And so there are paradigms when we think about competence, and I'm going to walk you through like a competency paradigm, okay? And by the way, love the templates for these slides. These are not my colors, but their colors are fantastic, and I figured I'd match. So when we think about the competency paradigm, we start with the concept of having a novice individual, an individual who has initial training, who is making their way through. And so the first thing that we have with that novice, so if I get that new person on my unit, what am I supposed to do? We got to talk about outcomes, right? They need to know what the standards are, right? So we want to have predefined and valid outcomes that we're going to hold people responsible for and say, hey, you know what? If you fall off this is what we're going to talk about, and this is what we're going to work on. That's the deal, right? And from there, we're going to start adding different things off of it, right? Because you know that they're going to come into our setup, but then they might go to different parts of the hospital system. They might go to the emergency department. They might go to the ICU. So we need to train them in their settings. We need to define this by settings where we train where they practice, right? So if I'm going to be the person who's on the Code Blue committee, I need to be used to being the person who runs into a room to do a resuscitation. That experience of actually running into a room and being half out of breath when I start a resuscitation, that experience matters. That does matter. And so then you have to get used to that concept, which is why we train our EMS professionals by running into a house. Right? You got to get used to that. And from there, now we no longer have a novice. We have an advanced beginner, someone who is able to start actually understanding and starting to do the basic things that we need them to do. But then we reinforce this. We can reinforce this in lots of different ways, right? We can improve them through deliberate, consistent practice. I mean, a lot of the frameworks that we will use with RQI are around this concept of deliberate practice to achieve outcomes and to keep doing it till you get it right. Right? And that's a lot of what we want to do. That is what gets us to the point of competence. So now I can honestly say, okay, you've made my benchmark. I'm so excited that you've made this benchmark. Now that you're there, guess what? You're confident. Have a nice day. No, we don't stop there, do we? And this is the challenge I'm going to push towards you guys. Because we do celebrate RQI. We celebrate our victory of actually assuring competency. But there's more, right? There's going to be more. There has to be more. And what that more is getting people to be expert. To get them to that mastery level of training, understanding and managing complex situations and patients, achieving optimal patient outcomes. This is the difference between 9% and 37%. Right? 9%, 37%. Where do you want to fall out? That's the difference. So this is a real challenge because now we're asking the question about how do we get someone all the way from my novice beginner, my advanced beginner, all the way to the level of expert or mastery learning. It's not a degree that does this. Though, sure, maybe you'll get closer to that because you'll have a good understanding. But I think all of us have seen the emergency physician who may be the board certified EMS doc who may not have done the best compressions for a second and gets called out by his team. That's the right thing to do. You should get called out, right? Because we're trying to do something here, and that means we're trying to save a life. So how do we get there? Well, the great part is there's a lot of research on simulation-based mastery training and how do we actually start thinking about these different things. And we've actually defined the flow through this whole process. And it's been published in Academic Medicine where they asked a simple question: how do we improve patient care processes and outcomes so that we can deliver high level of quality healthcare? And this is really important. So with that in mind, they gave us a flow chart. So what does that flow chart look like? So here you go. So this is a pretty detailed flow chart, and I'm going to kind of help you focus on some different pieces. Let's start the basics. We have said that if we do RQI and stuff like that, we're going to put people into the space of competence. So what does competence look like? So now when we take when I pulled up competence here, it says a good working background knowledge, able to address most tasks using their own judgment, and see actions at least partly in terms of long-term goals. It's not really all that inspiring. I think I need to work a little bit higher up the list, right? So let's talk about why we worry about that. Well, we all know that psychomotor skills degrade, and as skills degrade, also knowledge degrades, and all these different pieces all work together. We have hard facts on the concept of psychomotor skills degradation. This is Ormer's old paper, which really looked at a couple different aspects. They looked at compression depth, percent of compression adequate depth, and also ventilation volumes. And when they looked at all these different pieces, within 6 months to 9 months, you're seeing these huge drops. That's in your control group versus your experimental group, which is the black, continue to improve. So those basic concepts set the stage for what we're doing for competency, right? So we actually went through the fact of actually setting up RQI and looking at what competency looks like. My shop, and I am the ALS medical director for my shop at The Ohio State University. I have to put the D on, that's 5 cents. And so we did exactly this, and we put together our whole system. We actually evaluated it in 2020. We were looking at the concept of what is the impact of getting a large academic center like The Ohio State University and putting in a high frequency case-based psychomotor station with low dose pieces, and what the outcomes are for our in-hospital cardiac arrests. And so what we found in that study is we found that when we're doing assured competency in skills training, we do attain what we want. We attain assured competency in skills. We get high compliance rates when it comes to our in-hospital setting. So our compliance rates were like 97, 98%, and it still is, and we have 9,000 people on our system right now. And last but not least, we have improved in-hospital clinical CPR performance. So what do I mean by that? Well, we saw specifically in our units where we actually had people who are doing RQI versus other units who are not. And we looked at it actually on a pre-post nature as well as ramping in between our different sections. What we found specifically is our compression depth and rate were much more in target of where we want to be. Our fractions were better. So that means that over time, our performance that we were getting, that assured competency, was showing up in the clinical care at our code stat. And that's what I wanted to see, okay? Now, in our original study, when we did this, we didn't have outcomes because you need so many people to set up actually a study where you're actually looking at your outcomes. How many people you need? Well, if you look at the cardiac arrest studies done in the pre-hospital setting, when they're looking at the difference between continuous chest compressions and looking at 30 to 2, they had 10,000 patients in that study when they're actually looking at that in a randomized controlled trial. So really, when we think about looking at the outcomes of RQI, we're looking at unbelievably large patient populations. The real question is, do I need that to tell me where I am with patient care? I don't need that. I know what I need to do, and so we have invested in this. So one of the cool things for me is that coming here, and having been here before, so thank you again, was that I was able to actually look at time and look at engagement. And so I want to at least feed back something to you guys about how you guys are doing. And so one of the cool things I saw is that 74% of all the VA locations have 100% fully engaged with RQI for BLS. That's exciting. That is amazing considering how many different sites, 139 odd sites where you have that much engagement. Now let's even push it. That's 100% engagement. That's a really, really hard bar. Let's move that to 90%. And when you see 90%, you have 83% of the individuals engaged in RQI BLS. That is fantastic because now we know that we have a commitment in our community about assured competency. So we're hitting that competency mark, and as you heard earlier, we have a lot of people who are doing it. 210,000 people fit this bill in your group. And that is an amazing thing. And I'll be honest with you, this is not true at most academic centers, right? And that's crazy to me, but you guys are doing it. That means our vets are getting some of the best care they need. That's exciting to me. Now, when we think about this concept though, that's competency. We talked about competency a minute ago, and I'm going to bring you back to this image because I want to look at what competent versus proficient looks like. So now when we think about this concept, when I move to proficient, these individuals have a deeper understanding of discipline and areas of practice. They're able to take full responsibility for their work. They routinely achieve acceptable standards. Ooh, ouch. That's like stepping on a nail there. Acceptable standards, routinely achieve. Okay, fine. I'm happy you're getting there, but I kind of don't want to just do acceptable standards. That's not what I want, right? That's not what mom wants, right? And that's not what we want for mom. What we want to see is we want to see more than that. We need that adaptive expertise of what an expert is going to need. Excellence achieved with relative ease. Sees the overall picture. Sees alternative options. Recognizes patterns. Able to take responsibility for going beyond the existing standards. Creating their own interpretations. Understanding that that mom had a PE. Understanding that once we get her resuscitated, she's going to get her embolectomy. Once she gets her embolectomy, she's going to go to the ICU, and she's going to recover and go home with her family. That's an expert. And that's what happened with our story. That's exciting. That's what we want. Now, how do we get there as educators? So being an educator, I need a graph. Okay, I need a graph. On the horizontal is efficiency. On the vertical is my innovation. Okay, so that means that my adaptive expert has to put these different pieces together, and they're going to be, boop, in the upper corner. That is my adaptive expert who has not only the beautiful amounts of innovation and understanding this concept, but they're unbelievably efficient, and they're going to put it all together and do a great job for you. On the flip side, when my new person comes in, who they're just finished their school, they're all excited, they have that nice white coat, and they look great, they're down here. But they are purple, so I gave them something. So they are my novice who is working towards this. Now, you guys being educators, you're gonna feel me for this, and you're gonna just follow me through, is that sometimes you have that novice who feels like they're learning. They're not getting efficient. They're kind of a pain, but they think they're the best, right? They're super innovative. They're awesome. They're the best thing you ever see, and. Yeah, they're annoying. They're really annoying. And that's the person we want to avoid, right? Now on the flip side, you definitely have, I'm going to throw us under the bus. You have those docs. You just have those docs who, like, I went to medical school, I know what I'm doing. You know, I'm really good at what I do. I'm really efficient, but is algorithmic, really not thinking outside the box, and really does a good job, and that becomes a routine. That's the routine expert who's not learning beyond their scope and is really staying hampered in their space. They're just as dangerous as our annoying novice because they're never adapting and never pushing the agenda beyond so that we can do better. This is the challenge of us as educators. We got to piece through that. So we need to take all these people and push them up to that level. And the thing is, we have to do this with a kindly hand, with a smile on our face, right? Because you can't yell at them, because what's going to happen? They're going to disengage. That is the beauty of being an educator. You are persuasive. You're a convincer. Sometimes. So one of the approaches that we use to do this so that we can actually get people to where we need them to be is mastery learning. This is an instructional approach where educational progress actually happens with demonstrated performance. It has nothing to do with curricular time. So this is a completely different concept because most of our CEs, and a bunch of you are probably getting your CEs today, is based on how many hours I am sitting in a seat, right? That's my recertification. And the fact of the matter is, we're not recertification anything, right? I have no skills I'm learning except for listening to some guy talk about mastery training. That's okay. We'll get there. But the point of the fact is, we want our learners to accomplish an educational objective with little or no variation in outcome. So my one learner here is the same as my one learner here or my one learner here. They are all achieving the same outcome, and they're consistently doing this. Okay? It's not just what we're doing with our compression rates, it's all, or my depth or my fraction, it's the other steps. It's my teamwork. It's all those other pieces that we sometimes call that, unconscious or that invisible curriculum. We want to make it visible, and that's our standard. Now, one of the key characteristics of this is when you're getting to the point that they want to actually be a master, you need to serially test them. And you test them over and over again so that they have every ability and every chance to attain that mastery level. So when you think about this paradigm, what is it actually going to do for your learners? So I love a figure, again. So it really makes it more obvious. So the first bell-shaped curve is test number 1. This is my individual and all of my people who come into my system where I don't know what their skills are. So they have a nice, beautiful bell-shaped curve where their bell-shaped curve defines where they are when it comes to their training. So I have the people in the middle, I have the people on the ends, but I need them to be better, is what I need them to be. So how am I going to do that? Well, I'm going to set a new cut score. So you see my dark area going up. That is my new cut score. And I'm going to say to all of my learners, hey guys, you're doing awesome. You're really, really good. And I love how well trained you are. But today what we're going to do is we're going to actually push you. So here are my objectives for you. This is the things I need you to accomplish. Okay? And we're going to gauge you based off your ability to accomplish this. That's my cut score. So now I have a clear cut score, and I'm going to test them again, and it's going to shift my distribution, right? So my whole distribution shifts to a new space. If you've ever heard of bringing up the lowest 5%, that's what we're doing, right? Because when you have a team and you can bring up that lowest 5%, you'll be amazed at how culture shifts throughout the whole system. It's powerful. So now when we think about this, how does mastery come into action when we talk about it? So let's start with the basics. First, we get training engagement. Learners are given objectives and performance metrics, chances to train, and repeated formative testing with feedback. So when I talk about learners being given this, it's unbelievably transparent. This is transparency in action. Before they even show up, you give them the score sheet. You say, hey guys, this is what I'm rating you on. So for our emergency medicine residents in our program at Ohio State University, we have a mastery training program for airway management before they touch a patient. Okay? So does that mean they're going to be a master? No. It means that every single resident who comes in July, and you guys know the July effect, right? Every resident who comes in July has now gone through an airway training program so that they actually have all the skills and everything. They're not looking for different pieces. They know what they're supposed to do, and they know what architecture they're looking at when they get in that airway. There's no one looking away and looking for a tube and then losing the airway. None of that stuff is happening anymore. Because we're set clear objectives. In that first week when they come in, they go through our simulation lab and they sit there for the 4-hour time period till they master their skills. We do that for central lines, we do that for lumbar punctures, and of course we do that for resuscitation. Every one of our residents. And I'm lucky because I have a great simulation expert, Jennifer Yee at our shop, who does this and puts our residents through that. That's training engagement. The next piece is our performance goals. So learners cannot advance to their next level of performance without predetermined performance levels, and those have to be achieved. So going back to my residents, so one of my residents sits there and does airway management skills. They do a great job getting into the airway. They do awesome, and they're like, oh yeah, I got my tube, I put my tube in, and things like that, and they're done and they're enjoying themselves, and they're like, hey, great, look at what I did, look what I did. 2 minutes go by, and they're like, okay, well, are we done? And the simulationist looks at them and says, you haven't ventilated the patient. It's like these simple things that are immediate fails. You have to ventilate that patient with a bag valve mask after you get a tube in. That's a fact. I love that you're outside the simulated environment, but I need you to do this again, and let's ventilate the patient this time and make sure. Sure, it's probably a simulation effect, but I need you to prove it. Okay? And I want that redirection, because what's going to happen? Next time that resident is in front of a patient, intubates them, they ain't going to forget to ventilate that patient. Ever. It ain't going to happen, right? So last but not least, we want them to have a final benchmark. So taking again my residents that we have, they're going through this skills development. They can develop their skills to as much as they want, but we have a separate place where they go and they have to do their check-off. That's where they said they go in and they achieve their final consistent score, and it's done by somebody else. So through their simulation and formative response area, they have all these great trainers and educators who are there with them, but that checkoff space is a different person. And so now they all have to consistently achieve that same level of performance so that we make sure they're good. So this has been done for other disease processes. One of the classic ones that has been done for hospital-based systems that you guys are very well familiar with is central lines. We know there's lots of complications with central lines, bleeding, pneumothorax, CLABSI, right? I think a lot of us who are doing quality work understand CLABSIs. And what they did is they used a stringent form of this competency-based education and had that fixed passing standard like we said. They gave them specific feedback to gauge their performance, and they were taken through the mastery training pieces. And from there, they had a clear mastery standard, and they actually followed these patients. Jeff Barsuk did this, and he looked at a bunch of patients, a bunch of patients in their system as they went through, and they taught people how to do this. And what they found was our outcomes got better. And we don't have to focus on what the specific outcomes are, but we had better placement of our central lines and better success. What's more interesting is this next figure. In this figure, you see actually how they tracked them. In the first box, you have non-simulated trained residents, and you see all the complication rates of CLABSI on the vertical. Then you have the simulated residents, and look at what happened. All your risks and everything is going down. Then you have a new influx in July of non-trained residents again, and look it up. Everything's going back up again, my gosh. So we train them, and look what happens. Everything goes back down. So this works, right? So the real question is, can you do this with simulation? Can you do this with simulation with resuscitation, right? Well, guess what? People have tried. So we have a randomized controlled trial to talk about. So this trial looked at physiologic point of care CPR training to improve survival and favorable neurological outcomes. Happened in pediatric ICUs. Now, one of the things I have to tell you is where they did this. They did this in ICUs at some of the best pediatric hospitals in the country. And so they are the ones who are the research hubs who are looking at all these questions. They split people up randomly into two groups, either usual care, the stuff that they always do in their ICU to try to save a kid's life, and a bundled intervention. And the bundled interventional is all ICU staff trained in CPR with mannequins provided to their units and participating in monthly clinical event debriefing, okay? Really detailed work. And of course, they followed their outcomes of survival with favorable neurological outcome. So how did this look? So in their data of their study, what they found was their usual care had a survival rate of 52%, and their bundled intervention had a survival rate of 54%. So they said, okay, this is not different. Well, that's kind of sad, but is it? Who doesn't want their pediatric ICU to have a survival rate of 50% in a control group? That's amazing. These are sick kids, right? They have congenital diseases. These kids have cardiac arrest events, not infrequently, and it's scary as junk, but their survival rate is 50%? Well, the great part is this is exactly what the authors said. They said the survival rates in this study are greater than 50%, which is, even for the control group, which is the highest large-scale study that we've looked at in kids ever. There's a strong Hawthorne effect here. We're focusing on cardiac arrest. Every single person in this ICU is focusing on cardiac arrest. Even the control group, when they looked at the physiologic endpoints that the intervention group was designed to chase, which is diastolic blood pressures on these cardiac arrest patients, they all achieved the same outcome. So what does that mean? That means that when we actually put that intervention in that space, even the control group pulled the intervention through. So what does it mean? It means it worked. This kid tells us it worked. It means it worked, and that's an amazing thing, right? So that's the point. So it does work for resuscitation, and you can put these bundles of care into your personal systems. So how do we get our teams there? Okay, and so there's a lot of different strategies, and we're going to talk about some of these strategies here. And these are going to be things that are very familiar to you as we go through. Let's start with the basics, data collection. When we talk about data collection, this is actually looking at our data, tracking our data, and we have great data from what Paul said to us earlier, that if we look at the key aspects and we look at the details of our resuscitations and we track and evaluate that data, we are going to have more survivors. So that means that we have a responsibility on our side as educators and innovators to actually do our part to actually have the data ready. And not only have the data ready, but actually to feed back the data to everybody else. That's the first step. But how do you feed back this data? Well, the great news is debriefing is no longer our grandparents' debriefing. We just don't pull people aside and say, how do you feel about it anymore? We have data-driven debriefing now. So the debriefing tools that we use are data-informed debriefing, which have clear options on how to enhance care. Now, a randomized controlled trial done by Adam Chang really looked at this question of data-informed debriefing. So you can actually get exactly what their sheet is from their system and use it. And what they found is that when they used data-informed debriefing, they had improved guideline compliance across the board when it comes to traditional debriefing. And one of the figures right here is overall CPR analysis, and you can see that the larger group on top is doing significantly better than the lower group. So data-informed debriefing, you can grab these tools right from their paper and implement them. Now, one of the things that they did that I would say is a limitation is they focused on the data itself. So when they debriefed, they talked much more about those objective data of fraction, rate, things like that. A lot of us do that, but we could take it a step further and talk about, well, did you think this was preventable? Why do you think this is preventable? What were the key aspects? Well, Donna Edelson did exactly this, and this is a paper which is currently in press and just got accepted. And they looked at the fact that when you use data-informed debriefing, you can actually predict outcomes. Now that's exciting, right? And so on this figure right here, I'm going to take a second here. Gray is unpredictable arrests. White is predictable but not preventable. And the green is preventable and potentially preventable. Sorry, predictable and potentially preventable. And I have the survival rates there for you. The green, and I love how annoying that green is, tells you those people are savers. You could save them. Now, one cool part that they pointed out in their paper is they identified this specific group here. These are respiratory arrests which are predictable and potentially preventable. Can we put an intervention in our hospital system for that? You bet we can. We can definitely do more EtCO2 monitoring on those people. We can put closer airway kits. We can make sure that all the airway devices we have there, we can do our rapid response teams thinking specifically about more strict standards to get in that room and intubate that patient. We can intervene on that. Those are lives we're saving. And this is all from their structured debriefing that they added on top of data-directed debriefing. Wow, I'm having a hard time with that. Okay. So that's one piece. The next piece is teamwork and leadership. Now, teamwork and leadership looks different in every single shop. Now, everywhere you go, you're going to have different aspects or different concepts of what that needs to be. That needs to be clearly painted for your teams, what that looks like. So how would you paint what teamwork and what that leadership really looks like for your team? Well, you record it and you show them. Let me give you an example.
Roles are well defined, leading to good teamwork.
That's two.
Team demonstrates good verbal and nonverbal communication, helping facilitate care. The team provides quality CPR using feedback-optimized performance. Further, they have placed early end-tidal CO2 to help guide their resuscitation. Additionally, to decrease the perishock pauses, the team pre-charges prior to defibrillation, leading to minimal pauses. All of the steps we have described today directly impact patient survival with good neurological outcome. What we focused on are 1. High-quality compressions with adequate rate, depth, and recoil. 2. Ventilations with appropriate rate and volume. 3. Defibrillation delivered rapidly with minimal pauses in compression. And 4. Team dynamics, which lead to a coordinated response, optimizing all of the critical aspects of resuscitation. At DCEMS, an important aspect of success is feedback. It is important to evaluate our performance during a resuscitation by reviewing the CPR performance data. This data demonstrates overall quality of compressions provided, including the length of pauses in the resuscitation. Take particular note of the overall compression fraction, the depth and rate of compressions, and where compressions were not given and for how long.
So that's my team at Delaware County EMS. I am super proud of this team. We actually won the National Award for EMS Agents of the Year last year. And one of the things, I've been there with them for 10 years now, and this is the type of material that we put out. You can see it's nice, short, clean. We actually do more expansive trainings, obviously, but this is our reminder. So they get to see this on Zoom meetings, they get to see this intermittently during their training. And of course, when we put the training together for that switch, two of my biggest guys were the ones that we chose to show that switch because we wanted to show, hey, you can do it. It doesn't matter how big you are, you can do this, right? And so the concepts here, we could probably debrief that and find little things that we can improve on each of those different steps. But the key concept is the leadership, the communication you're seeing there, and the behaviors are transparent. That's the standard. And so when they come to the sim lab, and I put them in the sim lab, and they run into the house to do a resuscitation because we move our sim lab around, they come into the house, and they have to start a resuscitation, we videotape all of those. At the end of the videotape, they get to look at themselves. They get to watch and see how they did with their code, and we debrief them. Do they have a standard? Yes, here, take the standard home with you, because then you can look and see exactly what we're gonna hold you accountable for. So, when we think about all these different pieces, we put these all together, when all is said and done, we do wanna worry about how we can put it all together, and so what that special sauce might be. And I wish I could tell you it's gonna be A1, or maybe a little Worcestershire or something like that, but in truth, when we talk about the special sauce, it's kinda up to you how you put that together. All of our shops are a little different, the politics are different, those kind of realities exist, but the one thing that is the fundamental truth that we're not gonna get away from, and I stole this completely from Resuscitation Academy, who I help teach sometimes, is thoughtful implementation will facilitate meaningful change. And you need to be thoughtful. You need to be strategic. I need to think through what you want to do. Don't just run home and say, hey, here's the coolest new thing and I'm going to implement it. Think it through. Give yourself a month, couple months, even if you need a 6-month planning period to release. When we set out our resuscitation program at my agency, we took a solid year of planning, videotaping, and we actually got good production value out of it to make sure that we got something that people were going to watch. And there are actually systems that actually are there to help you figure this all out. And they're free to you. The AHRQ uses Team Steps. Many of you are probably familiar with Team Steps, but the fact of the matter is, a lot of times Team Steps gets a negative rap because people are required to do it, but some of the theories about how you set up your system are really, really good. So here's the basic concept here: pre-implementation, readiness assessment, getting ready, implementing planning, doing your training, and setting up that culture change in your system. These are real things that you can implement, and here's a real framework for you to take and use in your thought process of how you get there. So we've covered a lot of ground today. Okay, we've moved through lots of different things, and we've crossed a lot of bridges along the way. I love nature analogies, so you're gonna have to deal with me. But the fact of the matter is, some of the hardest things that we have yet to come are those mountains that we see in the distance. We have work to do. And some of those bridges that we build now with our colleagues, with the politics and all that, are the things that are gonna make us facilitate moving that next step. You guys have done the first step. Many of you have RQI in place. You have assured competency. That's the key. Now the question is, how do we make them experts? And that's what I'm gonna challenge you to do. When all is said and done, we make a difference. And our next step is where we're gonna make the difference, of moving us towards expert. And so I'm excited for your next phase in the work that you're doing. Thank you again. I'm open for some questions. I think we have a couple minutes left. Thanks again. Questions, thoughts? I may not have answers. Oh, this will be awesome. Am I ditching? Oh, we have one. There, okay. I see you now.
Yeah, hi.
Hi.
Thanks, it was wonderful. My question is for your training of your interns, that's through your hospital or through their school?
That's through our department does it. And so we started by doing that whole mastery training program within our department, the Department of Emergency Medicine, specifically for our residents. And it was so successful that we took it to our GMEC our Graduate Medical Education Committee, which is part, like the ACGME requires every hospital system to have that through their DIO. We presented it to them and they said, okay, let's do this. So they chose to do it for Central Lines. So now all of our intern class for Central Lines gets our mastery training program. And so we've done it minimally for that now, and surgery and a couple others will do other different pieces with us, but at least that we got that far so far.
Thank you.
Of course, and actually that work is published. So those checklists, all that kind of stuff is out there. Yeah.
Hi, Ash. Thank you so much.
Pleasure.
I'm always inspired by
Oh, thank you.
the things you have to say about resuscitation. We have a lot of people in this room, and I know as a health education specialist, you know, we're always proud to see our sites that are doing really well with RQI and competence. And we still are dealing with some sites who haven't quite adopted RQI. And some of those program directors are here in the room. So I just wanted to pose a question to you. Like, some of our challenges are, sometimes it's the leadership. Like, sometimes the hospital hasn't bought into the idea of quarterly training instead of, you know, every 2 years. And so I'm wondering if you had the group of leadership in this room that was not on board, like, what would you say to them to help them understand how important this is? You know, how are they sleeping at night is my question. But I mean, you know, what would you say to them, Ash? What would you?
No, I love that you gave me the easy question. I love it. No, I think, so I've fought these battles myself, but I think one of the big things that they all keep coming back to is they say this silly thing that, well, there's no evidence to support it, so I'm not gonna get into this because there's no evidence. And it's a really daunting statement because it shows a certain amount of naivete that it's really challenging to face, especially in your guys' positions. I think you have to come back and say, well, you know what? One of the big things that we have to think about is what kind of evidence are you looking for? We know CPR saves lives. We know that those skills are degrading every single minute. They're just degrading it, and there's facts to this. This is not something I'm just bringing out. There's real data, and I can show you papers around this, okay? We also know that the success rates and survival rates, risk stratified across the board, are so variable, and we probably don't even know where we are when it comes to risk stratified rates. We probably don't look at it that closely, okay? And recognizing that we have something we can intervene on, and something that we can start as a baseline to get us going, is not just reasonable, it should be the focus of where we're going. It's no longer okay to say that we are good enough when we can assure competency and actually be able to say that we are doing everything we can and we have proved that competency is there, especially when things are deteriorating. And I'm not saying that you have to do RQI. I'm not saying that. What I'm saying is you have to have assured competency because you cannot grow and become experts and have outcomes at 37%. You are writing it off. Right now, at this moment, when you make that decision, you're writing off any chance of having a success rate of 37%. And the fact of the matter is, it's almost ethical now. It's not just evidence, it's ethical. Because you're asking me to get a study with 10,000 people to prove in a randomized controlled trial that success will work. And the fact of the matter is, going to the pediatric study, we can show you one thing's true, is once you implement it, everybody picks it up, and when everybody picks it up, you get survivors. That's proof, right? I can't give you any more than that. And from this point, it's up to you, and it's the ethics around it which make the decision. Does that work? And if you have real problems, definitely call me. I will be glad to be an expert for that. They can throw me under the bus. Well, great, guys. If we have not, that's a great tone to stop at. Thank you so much. Have a nice day.